Gonna get started. Thank you for coming to Data Justice Debriefed, a panel discussion on what Oregon's groundbreaking new Data Justice Act means for demographic data collection in the state's health system and how it could change the way health disparities are addressed nationwide. My name is Jonathan Froxwijk. I use he, him pronouns, and I'm the Public Policy and Grants Manager for Cascade AIDS Project. I want to let you all know that you are visible, but you can turn off your cameras by clicking the stop video option at the bottom of your screen. You're muted now during the program, but you will be able to unmute during the audience Q&A at the end. And live transcript, closed captioning is available for this program. You can enable it by clicking live transcript at the bottom of your screen. And finally, ASL interpretation is available for the program. We have Edwin, our ASL interpreter here. Feel free to pin Edwin's tile if you need that accommodation. Next, I'd love to introduce our panelists. I'm really excited to have them here. So first we have Dr. Eileen Duldulao. Dr. Duldulao uses she and they pronouns and is a senior epidemiologist and research scientist at the Multnomah County Health Department. She has served on the Oregon Health Authority RealD Data Governance Committee since 2016. She's also a second-generation Filipino immigrant from the Ilocos region of the Philippines and grew up bilingual and bicultural in the San Francisco Bay Area. Dr. Duldulao is a founding member of the BIPOC Decolonizing Data Council and is co-chair of the board of directors for the Filipino Bayanihan Center. Next up, we have Jackie Yerby, who serves as the policy advisor for behavioral health and health licensing to Governor Kate Brown and co-leads the Racial Justice Council Health Equity Committee. Jackie also co-chairs the Basic Rights Oregon Board of Directors, and she served on CAP's own board from 2008 to 2014. Jackie holds a master's of public policy degree from the Kennedy School of Government at Harvard, where she studied health policy and international affairs and security. Then we've got Sean Cahill, PhD, who is Director of Health Policy Research at the Fenway Institute, Affiliate Associate Clinical Professor of Health Sciences at Northeastern University, and Adjunct Associate Professor at Boston University School of Public Health. Dr. Cahill serves on the Massachusetts Special Legislative Commission on LGBTQ Aging and is Associate Editor at LGBT Health. He has authored or co-authored over 100 peer-reviewed journal articles, books, chapters, and monographs on HIV, LGBTQ+ health, and LGBTQ+ policy issues. And last but not least, Dr. Andres Lopez, Research Director for the Coalition of Communities of Color, who is a trained sociologist and professional research and evaluation scientist. Academically, Dr. Lopez's training and research centered on how inequalities of race, gender, and sexuality are reproduced in organizations and urban settings. Dr. Lopez has over 10 years of experience conducting action research meant for solving social/practical problems and equitable evaluations of programs, processes, and organizations. Thanks to all the panelists for being here. So quick overview of what the program is going to consist of today. I will start by giving a presentation about the Data Justice Act itself so that we're all on the same page about the bill and what it does. Then the next segment will be an interview with the panelists where I'll ask the panelists questions. And then the last 10 minutes of the program, we'll open it up for audience questions. So without further ado, I will share my screen. Bear with me. Okay. Can the panelists give me a thumbs up if you can see my slide? Okay, great. So the Data Justice Act, House Bill 3159. Why did we need this bill? Very basically, Oregon does not have enough information to eliminate all the health issues that we know are disproportionately impacting BIPOC, LGBTQ people, people with disabilities, and other underserved populations. To give a few examples specifically related to LGBTQ communities, we know gay, lesbian, and bisexual adults in Oregon are more likely to report smoking tobacco. We know that lesbians are at higher risk of breast cancer. We know in a 2015 national survey of transgender people, 39% of respondents said they had experienced serious psychological distress in the past month, compared with 5% of the US population. But our knowledge of these disparities comes mostly from research by academic institutions and advocacy groups, not our own state's public health agency. So previous legislation has tried to address this problem. Back in 2013, House Bill 2134 required Oregon Health Authority and the Oregon Department of Human Services to collect race, ethnicity, preferred spoken and written language, and disability data through its own programs, for example, Oregon Health Plan enrollment. And that work has been progressing slowly, but it's been perennially under-resourced. So the progress has been a bit plodding. In 2020, just last year, the legislature passed House Bill 4212, which required providers to collect and report, again, race, ethnicity, preferred spoken and written language, and disability data for COVID-19 encounters specifically. So kind of the lay of the land was that before this bill, healthcare providers were only required to collect real-D data from COVID-19 patients, and providers were not required by law to collect any sexual orientation or gender identity data. That doesn't mean that providers weren't doing it. Some health systems were quite good on this, but there was no mandate from the state, and there was no uniform data standard or reporting up to public health agencies. So the management expert Peter Drucker says, what gets measured gets managed. How can Oregon manage institutional racism in healthcare or social determinants of LGBTQ health when we don't measure even the most basic characteristics of this population? We cannot achieve health equity without achieving data justice. So that's why we work to pass this bill, which on the highest level does two main things. It requires providers and insurers to collect and report to OHA data on patients' real-D and SOGI, race, ethnicity, language, disability, sexual orientation, and gender identity. And it directs OHA to develop a database for storing and analyzing that patient demographic data. Okay, now I'm going to run through what I'm calling the fine print. So the bill applies to all providers and insurers regulated by the state. We understand that this doesn't make sense for every kind of provider, so OHA will adopt rules for exempting certain kinds of providers. Providers and insurers must report the data at least once per calendar year, and the database must allow providers and insurers to query it to see if current patient data is is there. And finally, the database is required to have a functionality for patients to self-report their data. So one way this could look is that providers simply prompt patients to report their own data through an online portal. Providers and insurers may collect the data via electronic or paper forms, and they are permitted to report to OHA that a patient declined to answer REAL-D and SOGI questions. Providers and insurers must inform patients that REAL-D and SOGI data is reported to OHA, how the data is used, how the data may not be used, and that they're not required to answer REAL-D and SOGI questions. So this is about informed consent, making sure patients know exactly where their data is going and what their rights are. The agency is required to adopt rules establishing standards for collecting, securely transmitting, and reporting the data, and timelines for collecting and submitting the data. And they must do this in consultation with an advisory committee of people from communities affected by the policy. The data is considered confidential. It's not subject to disclosure under public record laws. It can only be released if anonymized and aggregated, and it cannot be considered by health insurers. Oregon Health Authority has the authority to impose fines for violations, but it must first provide notice of an alleged violation and give time to correct it. And the agency may not impose fines until it's established a process for data submission and it's built this database. OHA's required to report to the legislature no later than June 1st, 2022, and every 2 years thereafter on the implementation of the policy. And finally, the bill allocates $18.2 million in this upcoming biennium. The large majority of that is for staff in the Office of Equity and Inclusion, the Office of Information Systems, the Health Systems Division, and the Office of Health Information Technology. It's about 40 FTE. And a portion of the funds are set aside for a grant program for community-based organizations to provide training on culturally responsive, trauma-informed data collection. So that's the bill. At this point, I would love to turn to our panelists and talk about what it all means. I'd like to start with Jackie to hear about what's being done at OHA to implement the Data Justice Act and to hear about what community members' role is in that work.
Great. Thank you, Jonathan. And I just want to really highlight Jonathan's role in all of this, that when we were working, and I wasn't actually working with my colleague, Linda Roman, who was the health policy advisor at the time, but Linda coordinated closely with Jonathan throughout the legislative session to make sure that this bill passed and that it passed in a way that really was responsive to the community needs. So I just think it's really important that everybody know just how critical Jonathan was to getting the bill across the finish line and to where we are. So major kudos to you, Jonathan. And I don't know what your background is. So if you have a policy background, but just you did a phenomenal job, that's going to make a huge difference for Oregonians going forward. So thank you. So just to really amplify what Jonathan talked about, OHA is doing a lot of work to implement this bill, and they want to make sure that they are doing it really informed by the community. And so I will say that I think Jonathan had the number around like 40 staff. It's actually 44 staff across the Oregon Health Authority. And that's a lot. And so I think one of the challenges in the past with the previous legislation was the legislation was passed, but there wasn't actually the resources to really to bring it to life, to make it live and breathe. And so having the staff to really engage with the community, with affected community, to really shape like what this looks like, and to be able to ask those questions in a way that people will understand why it's important for them to respond and feel comfortable and safe in doing that. I mean, that's the community engagement piece is going to be so critical. And sorry, Tyler, I just saw your comment. So I'm not, Tyler, that is not what I'm doing here. So you don't have anything to worry about. Just really want to give credit where credit's due. Anyway, so the Oregon Health Authority is going to be embarking on this this Rules Advisory Committee, also known as a RAC, that will be focusing on SOGI standards, and that will be they'll be convening that in early next year, and that RAC will draft. They will start with draft standards developed over the past 2 years, and they estimate that they'll finish that work in June and July of 2022. And then also kind of concurrently, they will be convening advisory committees and work groups to inform the development of a roadmap for the registry and specifications. And, alongside the advisory committees, also doing community engagement to make sure that they understand the issues, concerns, and the desires relating to the registry. And then September and fall of 2022, so about a year from now, after getting this input about what the registry should look like, working on submitting what's called a policy option package for the next budget, so that so that OHA can get funding from the legislature to actually build the registry. And then spring of 2023, OHA will convene another rules advisory committee to create rules outlining requirements for providers, insurers relating to data submission to the registry. So that's kind of at a high level what the timelines look like. But I just really want to stress the critical element of community engagement through listening sessions, through advisory committees and work groups, and through these rules advisory committees.
Thanks, Jackie. And I'll take that prompt to put out to attendees that if you're interested in participating, you can reach out to Marjorie McGee, who is the Realty SOGI program director. I may not be getting her title correct, but I'll share her email in the chat so that you can reach out. She's invited anybody who's interested in participating on a rulemaking advisory committee to reach out. Staying with you, Jackie, first of all, thanks for the kind words. And Linda Rahman from the governor's office was a huge help to CAP. The governor's office was truly in on the ground floor on this policy. And I wanted to ask you why Realty and SOGI data collection was a priority for the governor.
And thanks for that question, Jonathan. And in this case, I will give a lot of credit to Tyler Termeer, CAP's CEO. So last year, in response to so many things going on, in response to disproportionate impacts of COVID on our BIPOC communities, on LGBTQ plus folks, and also, the racial reckoning that came as a result of the murder of George Floyd, on top of, all the other, on top of everything else, that the governor created the first ever Racial Justice Council, and there are subcommittees of the Racial Justice Council, and so the inaugural Health Equity Committee of the Racial Justice Council, I co-led with Linda Roman, who again was the health policy advisor at the time, and Tyler Termier continues to be part of that table. So so I'm going to back up a bit to talk about conversations that Tyler and other leaders in the community had with the governor's office and with the Oregon Health Authority to say, hey, our communities are being disproportionately harmed by COVID. And we have all of this kind of anecdotal information, but we need kind of real data that is kind of responsive to the community, that the community is part of shaping what the questions are, how that data is asked and how that data is used. That we need that information in order to really have a true picture of what's going on with COVID, and to make sure that we're allocating resources based on that data. And I think as you touched upon, Jonathan, like we did have that 2013 legislation that I will say kind of built a system around Real D, but SOGI was not part of that. And also it was kind of like OHA had a system, but there weren't requirements for providers and insurers to actually collect and provide that information. And so there was just this huge gap of information that we needed to rectify. And again, a lot of credit goes to Tyler and his peers for really lifting that up to the governor's office, to OHA, to the Racial Justice Council Health Equity Committee. And through all of that, the Health Equity Committee made Real D and SOGI like one of our priority pieces of legislation to get passed.
Thank you. I'd like to turn to Dr. Lopez, because the organization that you work for, Coalition of Communities of Color, often uses data to inform policy advocacy. So I wanted to ask how you think this more robust Real D and SOGI data will help your organization and other community-based organizations create systems change on behalf of communities of color and LGBTQ communities.
Yes, thank you, Jonathan. First, I want to say that what's so important about this bill and what's to come for Oregon is that having SOGI data really visibilizes the lives of so many Oregonians. It really allows us to better understand the diversity of our population and the different intersections that people experience, right? That are fundamental to legislating or to providing support, right? And also I want to say that having better data around both sexuality and gender, right, allows us to have more nuance and complexity and really understanding lived experiences. It moves us past the sex binary of male, female, right? And it also helps us to understand how heterosexuality and heteronormativity are really centered in everyday life and in our institutions, right? So that's really important. So I just want to start by saying visibilizing our communities is really essential. And that is more than just identity. It's more than just visibilizing those who have certain identities. It is also visibilizing how social structures then organize and provide different resources and experiences of power and equality differently to folks based on sex and gender, sexuality and gender, right? So that's really, really important, because oftentimes when we hear these things, people just talk about identity. as if it's just how I feel and not about how our world is fundamentally organized, right? And that's really, really important. When it comes to how we would use this data for the good of Oregonians, right? And particularly thinking about BIPOC communities who we really focus on in the communities of coalition. I think about a few things. One, I think about bringing our realities into systems. So when we can identify gender and sexuality in specific ways, this requires systems to now start thinking about what it means to provide services, to provide support, to even understand how our systems operate. So that's back to the visibility piece, right? We are sort of invisible in how we exist in different systems. I think the most obvious one is around resource allocation, right? So really sort of, we often think about this when we're talking about communities of color, where for the last, I don't know how many years, we've been trying to convince people that racism is a real thing and that it's structural. And the only way to do that is by showing some data that helps sort of the dominant narrative understand that racism is real and it actually manifests itself pretty normally in everyday life in lots of different structures in different ways, right? The same thing happens for those with different sexual or non-dominant, right, sexual and gender identities, right? And so being able to understand the reality of gender non-conforming folks, queer folks, trans folks, helps us then really advocate for the need for services and resources. And the last piece about this that I wanted to say is that it also helps us think about providing more holistic care, right? So the more that we can understand how these different intersections of people's lives, be it race, gender, sexuality, class, ability, right? Then we start understanding how our systems need to provide care in really specific ways, in ways that are mindful of past harms and of past ways of really centering the dominant, right? And it's not just in healthcare, because health is connected to all of the things. So this has impact in education and in housing and in food systems, right? Like these things are all connected. So what really excites me is that this will lead to other agencies, other systems in our state to also collect and track race or gender and sexuality data, right, that could also be used in sort of these three ways. So it's really, really, really exciting to me that we will be able to have more meaningful discussions about people's full lives, and then that will have a lot of implications across different systems, particularly for those most marginalized, right? And I think the last thing I want to say is that I think about the youth. When I look at the data that we have from Oregon Healthy Teens or from Student Health Survey, the data that our state knows about young folks, right? Young folks are much more tapped into their understandings and under their understandings of their identities and of the ways in which the world sort of situates people based on gender and sexuality. They're with it. They're identifying, they're making sense of it, they're learning with each other, right? And if we don't update our systems to be able to meet the youth, right, who are our future, then we're really missing out on we're erasing so many people's experiences and realities and opportunities for better, healthier systems. So that's sort of my initial thoughts. I could just talk about this all day. I'm so excited, but just wanted to share a few of those pieces.
Thanks, Dr. Lopez. We're here for nerding out about the data. Now I'd like to turn to Sean Cahill as somebody who is also very familiar with, kind of turning research into action. I'm wondering if you could give us a concrete example or two of how you think SOGI data collection and healthcare can help improve the health of LGBTQ people?
Sure. Well, Jonathan, the goals of public health are promoting health, preventing disease, and prolonging life. Those are the goals according to the World Health Organization. And it's really critical that we collect SOGI data so that we can, in a very basic way, document health disparities and establish that they exist so that we can then figure out a way to address them and try to reduce and eliminate them. And so some concrete examples would be, it's really important to have this information so that you can inform preventive cancer screenings. If a provider, so we know from survey data like the Behavioral Risk Factor Survey that sexual minority women, cisgender, lesbian, and bisexual women are less likely to get preventive cancer screenings like Pap tests, mammograms. This is also true of mostly heterosexual, cisgender, Black and Latina women. And so then the intersectional population of Black and Latina, lesbian and bisexual women would be a particular priority population for promoting preventive cancer screenings. We also know that risk factors for those cancers include nulliparity, which is never having given birth. And on average, lesbian and bisexual women, even though many do give birth to children, on average, they're less likely to do so than heterosexual women. And so, so they actually may be at greater risk for breast cancer and ovarian cancer, but we know that they're less likely to get a mammogram and a Pap test to screen for cervical cancer. So that's one example. Another example would be gay and bisexual men, and that's also true what I just said for transgender people on the masculine spectrum, transgender men and other people who are assigned female sex at birth, but are on the masculine spectrum. And then if you look at gay and bisexual men and transgender women, we have much higher rates of HIV and hepatitis A and B than the general population. And that disparity intersects a lot with racial ethnic disparities, particularly in HIV among African Americans. So gay and bisexual men and transgender women might represent maybe 2 or 3% of the overall adult population, yet about 70% of new HIV infections in this country occur among gay and bisexual men and transgender women. About 10% of new hepatitis A diagnoses and about 20% of hepatitis B diagnoses. So what we can do with that data, and that a lot of that data is from survey data. So now that you have this bill that's requiring the reporting of clinical data, it's really great because those data very well complement the survey data. In some ways, they may be more accurate data because sometimes when people self-report that they were diagnosed with a condition, they make a mistake, they get it wrong, or if they're self-reporting risk behaviors, they might not tell the truth about, their smoking history or their substance use. And so this data really complements the population level data. And it allows us to target interventions that are about prevention and screening. And that has huge public health implications.
Thank you. Staying with you, Sean, in terms of, I'll let you take a sip of water. In terms of SOGI data collection, with the enactment of this policy, how does Oregon now compare with other states and the federal government? Since you're our only panelist sitting outside of Oregon and who keeps a really close eye on policy developments nationally.
Mm-hmm. Yeah, I want to join the other panelists in congratulating you and Tyler and all of the governmental and community leaders who really helped this bill become a reality. It's a historic bill. To my knowledge, it's the only one of its kind in the country. So you're the first state to actually do this. And that's a huge step forward. And it really inspires us in Massachusetts and around the country to try to get something similar done in our states. In terms of collecting data in regard to COVID-19, that's incredibly important. As far as I know, based on research that I've done, I just published a paper in the American Journal of Public Health. You're one of 5 states that's collecting data related to COVID-19 testing, care, and vaccination uptake. And all of that will be collected eventually through the clinical data that this law will mandate be reported to the state health agency. So that's really great. And that's important because, so you're one of 5 states along with California, Nevada, Pennsylvania, Rhode Island, and the District of Columbia. And unfortunately, the federal government has not taken steps to even encourage the collection and reporting of COVID-19 data, of SOGI data in COVID-19. And we have lots of data that tell us that LGBTQ plus people are probably more likely to contract COVID-19, to test positive for it. That's because of things like we're twice as likely to work in public-facing professions like retail and food services, or healthcare or education. We are also more likely to have certain chronic conditions that if you have that condition like diabetes or obesity, and then you get COVID-19, you're more likely to develop complications, and you may be more likely to be hospitalized and so forth. And then we also know that LGBTQ plus people have higher rates of risk behaviors that could complicate our ability to deal with COVID, like smoking, vaping, substance use, a lot of which is related to dealing with the impact of stigma and discrimination, minority stress, stigma, and so on, social anxiety. And then we know that there's a lot of discrimination and medical mistrust, particularly among BIPOC people who are LGBTQ, older people, transgender people, intersex people, based on negative experiences with the healthcare system, with the government. And so there's a lot of mistrust, and that could affect vaccine uptake. So it's really critical that we collect these data. And I'm so grateful to you all for being this example for the rest of the country that will actually make it easier for us to push through changes in our states and with the federal government.
Thanks, Sean. So now I want to turn to Dr. Jewel Delau, because before we break our arms patting ourselves on the back, we have a lot of work to do to implement this policy and get it right and continue to be a model for other states. I'm hoping you can speak to what you see as the greatest challenges ahead for the Data Justice Act's implementation as a public health worker and epidemiologist.
Thanks, Jonathan. I think that when data folks saw that the bill was asking for this registry database, a lot of folks got really overwhelmed because it's a huge lift, right? And there's definitely real IT challenges that we face building the registry, as well as restructuring electronic health records and other systems to accommodate the collection of not only RealD data, but also SOGI data, shifting workflows and things like that. But as we learn with RealD, these are very real challenges that will require resources, which luckily we have, and a lot of real hard work. But they are in no way impossible or insurmountable. I think that the bigger challenge, and one that can be viewed as kind of philosophical, but also is very real, is training and reorienting those who work with data, the analysts, the epidemiologists, the data scientists, in understanding how to work with RealD and SOGI data, and understanding the fluidity in which what these categories mean and what they don't mean, and how some are chosen and some are ascribed. Data is subjective, and RealD and SOGI data is subjective, and really at the root of it reflects relationships, and relationships to structural oppression, to these institutions that have really deeply embedded structural racism and structural oppression. And the challenge and really the opportunity, I think, is for us to work with data folks to shift the paradigm of looking at data as a static, objective representation of reality, to really developing an authentic understanding of the complexity of the relationships and lived experiences RealD and SOGI categories are meant to reflect, right? These are, and it's something that I talk to analysts about all the time, is that these are not static categories. These are, in a lot of ways, proxies for experiences of oppression. These are not in any way, shape, or form meant to represent anything biological, and to some extent are really limited in their ability to reflect people's identity or even cultural identity. Real D contains a Filipino box, but when I'm back home in the Philippines, I identify as Ilocana. And that's really, it's really only here in this country that I identify as Filipino or Asian American. And to some degree, those categories are not chosen for me, they're ascribed. And so I think that it's really important for analysts to understand that when they're working with the data, and to understand, how also their relationships to these identities, to these communities, may shape how they analyze the data and how they make meaning of the data. I'm really excited because I think that this will give us an opportunity to really get the analysts and the epidemiologists and the data folks, get them from out from behind the computer screen and get them in real relationship with the communities that are most impacted by health disparities. And so, to echo what Jackie talked about, that community aspect is really, really important, but also getting the folks that work with the data, the analysts, the folks that will be pulling the data, to get them in relationship with the folks most impacted by the data to help make meaning of that data. And I think I'm really excited about that opportunity to move really towards data justice, but also decolonizing data and putting the folks most impacted by health disparities as reflected in Real D and SOGI categories at the center of these data collection and data meaning-making practices.
Thank you, Dr. Gildelau. So I want to leave time for the audience to ask questions of our panelists. I see one in the Q&A, which Sean Cahill already kind of responded to, I guess, but other states, are you aware? Let me go ahead and read the question. Are other states looking to, oh, it just disappeared for me. Maybe because you typed a response?
I just answered it, so sorry about that.
Would you mind reading your answer for everybody?
Yeah, so basically the question was, is the Data Justice Act inspiring activists in other states? And I said, absolutely. I know of efforts in Illinois, Pennsylvania, Maine, Massachusetts. I know there's people across the country trying to pass comprehensive SOGI data bills that require the collection and reporting of voluntary SOGI data so we can better understand disparities and address and reduce and eliminate them. So absolutely.
That's great to hear. If you have a question, you can type it in the Q&A box, or you can go ahead and it looks like you can go ahead and unmute and ask. Questions?
I see a question in the chat and a question in the Q&A. So I see two questions.
Oh, thank you, Sean.
Should I read them or do you see them?
I can see them now. So Arthur Towers asks, was there much opposition to the bill and what was the nature of it? I think I'm probably best positioned to answer that. And I'll just say that I think there wasn't necessarily opposition. There were a lot of questions and concerns from particularly the provider community and health systems. Advocating for the bill required a lot of discussion of what safeguards and sort of rails they needed in the legislation to feel comfortable with it, I do think that everybody was supportive of the idea and wanted to get to yes. So things like making clear that providers could report to OHA that a patient had declined to answer the questions versus having them on the hook for potentially being in violation of the law because somebody had declined to provide that data. Things like that, it was important to providers that we kind of enshrine that in statute, and we were able to get there. Let's see. I'm gonna go with Molly C asks, are there any books or articles on decolonizing data that you would recommend? Dr. Jewel Delau, does anything come to mind for you?
Yes, actually, let me pull something right off my my bookshelf. There's quite a few. There's decolonizing methodologies. I don't know if you can see this. This is a classic, I think, in indigenizing and decolonizing research methods, and it's by Linda Tuhiwai Smith, who is a Maori researcher out in New Zealand. But Molly, I also sent you my email address if you want to go ahead and email me, and we can I can send you a list of other articles and things like that that the BIPOC Decolonizing Data Group are currently using as there's a lot of things that you could start looking at, but I'm happy to share. Thanks.
Thank you, Dr. Jewel Delau. Julia, whose name I will not be able to pronounce, I'm so sorry. And I have a similar name, so. But they ask, what are the immediate next steps and how can community members, researchers, and providers get engaged in supporting the implementation of this law? I did drop in the chat and hopefully folks can see it, Marjorie McGee's email address. And that she would be a good person to reach out to serve on one of these rulemaking advisory committees or just provide input. Otherwise, you're welcome to reach out directly to me and I can connect you. Let's see. An anonymous attendee asks, what types of providers are exempt from the Data Justice Act? At this point, no providers are exempt, but part of the law is directing OHA to establish a process for exemption. So for example, an example that came up during the legislative process was EMS providers, EMS technicians who are licensed by the state, but obviously it doesn't make sense to collect somebody's real D and SOGI data when they're in an urgent situation, an emergency care situation. So we definitely anticipate that certain kinds of providers will be considered by the agency for exemption on a case-by-case basis. Let's see. Jennifer Parish Taylor from the Urban League of Portland asks, do you see this push for real D and SOGI data collection in other industries beyond healthcare? Let's see. I would open that up to any of the panelists who'd like to answer. Sean,
yeah, I'll make a comment about that. It's a great question. You know, the Biden-Harris administration has done a lot of great, has taken a lot of great steps in relation to LGBTQI plus healthcare and health equity, as well as racial ethnic health equity, and of course the intersection of those two populations and issues. In response to executive orders put out on Inauguration Day and some guidance from the Office of Civil Rights at Health and Human Services in May, saying that sex discrimination will be understood to include sexual orientation and gender identity discrimination in healthcare, a number of agencies outside of HHS have started to add SOGI questions to surveys or forms that they use in their work. So an example is the Consumer Financial Protection Bureau, which looks at things like mortgage lending, small business lending, and so they actually reached out to a number of us sort of SOGI data advocates and researchers and asked for guidance in how to put those questions onto their forms. So up until now, their form for, I think for a mortgage, which if you go into a bank and try to take out a mortgage, you'll use this form, has a sex question, probably with male, female, other, and that's it. That's usually what's on government forms, or just male, female. And they're gonna add a current gender identity and a sexual orientation question. So I think that's happening more and more with other agencies as well.
Thank you. Taylor Pinsent asks, do you see any issues or have any concerns with internet-based data collection for the self-reported data? Taylor, I think I know what you mean, but would you be willing to unmute and say a little bit more?
Sure. Can you hear me okay?
Yeah.
And sorry, I realized I put it in the chat instead of the Q&A, so hopefully that didn't confuse you.
No worries.
So when you were introducing, I think it was probably part of kind of the rollout, I thought you had mentioned that there would be kind of a portal for kind of the self-reported piece. So I just wanted to hear a little bit more about that, if there is any more. I know it's being kind of built out or starting to be built out on the roadmap, but if there's any concerns related to collection in that way or barriers that you see.
Concern with security or concern with accessibility or?
I would say concern with the accessibility.
Right, so that will be one of several ways that the data could be collected. You know, this data can be collected orally in the exam room by the provider. It could be collected on a paper form, or it could be, like I said, like just a prompt from a provider to submit the data on their own. So I guess I see that, you know, we're trying to come up with many different access points for patients for this data to get submitted. Does that answer your question?
Yeah, I was just kind of curious because I know that, you know, even with the Real D data collection now, we have a problem with some providers just, you know, looking at a person and clicking boxes. And so, you know, just thinking through one, accessibility of something that's like based on the like an internet-based portal type thing, and then also just issues around making sure it's collected correctly.
Yeah, Dr. Jodala, I'm wondering if you have any thoughts about that. Not to put you on the spot.
I have a lot of thoughts about that. Hi, Taylor. You know, I think that the implementation piece is something that we're going to have to really look at closely and really understand that this data will only be as good as we're able to implement it within the context of data justice, right? We can't have people just looking at people and checking off the boxes. We have to make sure that folks are able to have a voice in terms of what boxes to check and things like that. So, you know, I know that we've have a lot of lessons learned regarding Real D. And there's been a lot of issues in terms of the implementation and you know, how are the questions asked? Are they asked in a way that's respectful? Are we allowing folks to actually self-identify and things like that? And so I think that what we're going to have to do is really look at the lessons that we learn with Real D and apply them, and really pay attention not only to the mechanics of implementation, like how do you ask these questions, but again, going back to what I talked about, when you're asking the people that ask these questions, what's their relationship to these issues of structural oppression? What's their relationship to these institutions? Do they understand why they're asking this information? And I think that that's going to be a really integral part of making sure that we get reliable and valid RealD and SOGI data. And it's part of the data collection process that we oftentimes don't address is the person actually collecting the data and their training and their orientation and shifting their paradigm as well.
I just want to mention, I answered a couple of questions in the chat, I think. David's question and another question about sort of internet, answering the questions via the internet.
Jonathan, you're muted.
Thank you. I said, in that case, why don't we take one last question, because I've seen a couple people kind of +1 it in the chat. David Cuevas asks, what about death certificates? Did the law include them? I'm not sure about this. Jackie may be able to answer, but I think that may have been something that OHA was already directed, at least, to incorporate RealD data by the 2013 bill, but probably not SOGI data. Do you know about that, Jackie?
You know, that's a good question. And I see my colleague, Belle Shepherd from the Oregon Health Authority on here. You know, I saw the question and I went back and I read the bill, House Bill 3159, and the Oregon Board of Mortuary and Cemetery Board was not specifically called out. And so it's not specifically listed in the bill. And I should say, I don't know the mechanics of how like a death certificate is done. So like, but the absence, I'd say, of the Mortuary and Cemetery Board makes me think that that is not included in SOGI and RealD, but I can also check with Belle and with the board to see, but that seems like an important place where we would want to have that information.
Yeah, and feel free to follow up with me, David, for more information about that. I'm interested personally. And since we're at 1:01, I'm gonna let the panelists carry on with their day. Thank you so much to all of you for participating. I just want to, if you're interested in learning more about CAP's public policy and advocacy work, you can go to capnw.org/PPA. So capnw.org/PPA. We do a monthly newsletter about our work. And have a good afternoon, everybody. Thank you so much.